Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
So today we are continuing on our topic of gastrointestinal issues, and we're talking about a disease that is on the rise, and it's actually the most common cause of liver disease in the world, and that is fatty liver disease.
And today we have a very special guest to help us unpack this diagnosis, Kyle Bloomfield, who is a nurse practitioner at Baptist Health here locally in Lexington. And he has specialized in gastroenterology and worked in this department for many years now.
Thank you all so very much to have me here. It's an absolute honor to be on your podcast today.
We're glad to have you.
We are.
And can you give our listeners a little bit of an introduction about yourself?
All right. I have been born and raised here in the great bluegrass state of Kentucky. I'm originally from northeastern Kentucky, bit of a conundrum. I was essentially had a Lewis County address my whole life, but went to school in Carter County, then went to undergrad in Pikeville before I moved up here to Lexington. I've been at Central Baptist or Baptist Health Lexington ever since. Education-wise, undergrad was on Pikeville. I got my RN and BS in there. When I came to Baptist Health, I had the privilege of working with two attendings there who really encouraged me to go on to graduate school, where I got my master's as an adult gerontology acute care nurse practitioner. And along the way, too, I developed this fascination and love for GI, as well as general surgery, colorectal surgery. Anything in the belly was really the things I was most interested in. And then the things with the liver really caught my eye from a very early stage. And then also, too, those same attendings told me to go on to school, and I went and got a doctorate where I spent 2.5 years researching liver disease in particular on a focus of fatty liver, diet, lifestyle, nutrition.
That's great. We are looking forward to diving into a lot more depth with fatty liver disease with you. And we're going to be talking about what fatty liver disease is, why some people develop fatty liver disease, also the new names for fatty liver disease because it's changed.
I know. Now it's just very confusing.
A little more complicated for sure.
And then we're going to talk about how someone might know they have it, what tests are involved, and then, of course, what we can do about it, particularly with lifestyle, because this is a disease that, although it's alarming with the rates going up and we're even seeing fatty liver disease in children, it is something that we do have some control over and new medications coming out to help. So I'm excited to get a chance to talk about this topic with you today.
So to get us started, can you tell our listeners what is fatty liver disease?
Yeah, so when I'm meeting a patient for the very first time and we're talking about fatty liver, I try to break it down into as simple terms as possible. So fatty liver at its core is just us saying your liver has went on this little rampage and has decided to store extra fat in the liver. What does that truly mean? And the analogy I always use is imagine you're building a home and you're having someone come out and brick that house for you. You want nothing on one side of your house but just nice queen-size bricks stacked neatly and uniformly. Your liver is structured much like a brick wall, made up of all these millions of little hepatocytes that are nice and neat and uniform. You have this nice clean wall. Your neighbor, on the other hand, has a house that has a doorway, an archway, a stained glass window, a mounted TV bracket in the middle. Those cells, instead of being nice and uniform, now have big gaps in them. Fatty liver is much like that wall, and you now have all these gaps and these deposits where they're not supposed to be. In and of itself, not a dangerous situation to have those deposits and those gaps in your cells, but over time you can get some weakness around the mortar joints and around the caulking around those windows, and that can create some instability, some inflammation. Over time you can have issues.
That's a great way to think about it.
I think another thing we just need to clarify from the very beginning is some of the nomenclature around this disease state, because it was called one thing and now there's another name for it, and it's just gotten a little confusing. So let's just give some of those definitions so our listeners understand exactly what we're talking about when we use words like NASH or NAFLD, or even the new one, the metabolic dysfunction associated steatotic liver disease. That's a mouthful.
It is.
Massled.
Yeah,
Massled.
yeah.
So can you just define these for us?
Yeah, of course. So back in the earliest I can recall was in 2023, the American Association for the Study of Liver Disease released these joint statements where wanting us to start calling things more of what they are as opposed to what they are not. Back in the day, we were using phrases like non-alcoholic fatty liver or NASH, and really we weren't dialing into what was truly going on in those livers. So now we have this new steatotic liver disease classification system. And the big thing to remember is we want to look at this more broad terms. In the olden days, you had NASH and NAFLD, or non-alcoholic steatohepatitis, or non-alcoholic fatty liver disease. Those two got an upgrade, and they are now metabolic associated steatohepatitis, and then the metabolic associated steatotic liver disease. So they're uniform and they can be interchanged in the same thing. But what they did for us is they gave us a murky middle. So what do you say to a patient who tells you, hey, I drink 2 glasses of wine with dinner 2 or 3 nights a week? Is that playing a role with their liver disease? So what they did is they created this new middle category that we call MET-ALD, and that's how you're supposed to say it, MET-ALD. And that is for your patients with social to low ranges of alcohol consumption. So we can now quantify, hey, is your alcohol consumption playing in any way into your liver disease or fatty liver? So for example, if you're a female and you're drinking 2 glasses of wine 3 nights a week, that would only be 84 grams of alcohol consumed in that week period. So you'd still be in the massled end of the spectrum, whereas if you double that or even triple that, you'd fall into the more alcohol-leaning ALD end of that spectrum. So it just gave us a better tool to tell patients, hey, this is what's going on in your liver and this is why it's happening.
Yeah, so to try to simplify that, it seems like there's the massled is fatty deposits in the liver.
Correct.
Due to non-alcohol, due to diet and other things, which we'll get into.
Correct.
And then the MET-ALD is probably both.
It can be, yeah, that's the confusing part. Is it can be both, and there's a sliding scale. So you just look at their alcohol consumption, and you say, okay, you're drinking how many drinks? You calculate it in grams per week, and you just put a line down. Okay, you're right in the middle, so this could be either or it's heavier towards the metabolic alcohol end of the spectrum.
I'm glad they did that, because I always found that really confusing, because there are many people that don't fall on one end of the spectrum, and when trying to provide advice of what to do or what was the actual etiology, when you're in that middle ground, it's easier now to say, hey, it's likely both.
Yeah, and in my first few years in practice, that was one of the most frustrating things for me, because I like to be really concise with my documentation. And when I'm like, oh, there's fatty liver, but they drink some alcohol, and I had to say NASH with occasional alcohol. It wasn't real clean and concise like I like. So this was a great adjustment. It's just taken the society a long time to roll out the education and get people on board with using it. I myself am guilty. I will still call something NAFLD instead of the massled, and it's going to take time.
So really, we want our listeners to know, you might hear all these terms because doctors are trying to get used to using some of this new terminology, but we're slowly adjusting.
Yeah, it'll be a process for sure. And then the other thing for the listeners is when you're getting imaging, you'll see some people say fatty liver infiltration on an ultrasound, and then another radiologist will say hepatic steatosis. So this whole thing, there's a whole myriad of words we use, but it all comes back to the same thing.
Yeah, and it might be something that your doctor's never brought up to you, but you might see like on your after visit summary, and there's all those diagnoses on there, and you might see one of these, the NAFLD or the massled or the NASH or MASH or hepatic steatosis listed.
Correct.
So if you see any of those things, it all basically means fatty liver, which is probably how we'll talk about it today.
And
yes,
this show is
sure.
for you.
Yeah.
When it comes to that. Because many times when you've even seen it on imaging, someone may not have even brought it up to you because they may have been getting an image of some other part of your body and they just mentioned this in your liver and they didn't talk about the fatty infiltration that was seen in your liver. So if you have seen that, this is something I would go back to your primary care doctor and say, hey, when I had this CT scan a few months ago, it mentioned this. Can we talk about that? Because sometimes if you get an image with a different specialist or in the ER, et cetera, it's not brought up. So,
yeah. And I think we're just so immune to it as doctors because we see it on almost every scan we order, some mention of that we get to where we just don't even bring it up. And when it is at those mild stages, that's when we really do need to be bringing it up.
Correct. That's when it is the most reversible and the easiest to address. So we are 100% just immune to seeing it every day on every scan.
Because these numbers have just skyrocketed.
Absolutely, yeah. When you look at the numbers, 1 in 4 adults now have fatty liver in America. And the scary statistic for me is when you look at the new pediatric data, up to 10% of kids have fatty liver, so 1 in 10 in your classroom. And a lot of that's just mind-boggling to me as a provider to see that even if I'm making these changes in my adult patients, the foundation for that's already been started well before I come in contact with them.
And this was just not something we saw in pediatrics 30 years ago.
Before we get into a lot of details, can you just tell us, why do we even care? You mentioned having a little fat in your liver isn't that big of a deal. So why do we care about this? What could potentially happen?
Going back to my analogy of the house and the bricks, when you start getting those fatty deposits in your brick wall, you start to end up with inflammation. Those things start to break down around your mortar joist. Within your liver, that same process happens, and you start with the fat leads to inflammation, that leads to fibrosis, and long-term, you end up with cirrhosis of the liver, which is pretty much a non-changeable condition. That's a chronic condition from that point forward. My role as a gastroenterology provider is to identify your fatty liver well before we progress to cirrhosis, because at that point, it's just a strictly management thing that we try to manage your symptoms and things as best we can, as opposed to being really curative. So the big thing to know is the fatty liver in and of itself may not be dangerous, but if we don't do anything about it long term over the course of 15, 20, 30 years, it can become a very real problem for you.
Now, you had mentioned the fatty liver can turn into fibrosis. Is fibrosis in itself reversible at that point?
Fibrosis, as long as we catch it before you get to F4, is reversible. F4 on the classification system is when we start calling that fibrosis cirrhosis. So as long as we catch it in time and we see it in time, then there's plenty we can do about it.
Yeah, I think of it, if you get a bad scrape on your leg falling on the sidewalk, and that turns into a scar, you can picture that in your mind. You had all that inflammation, and then that eventually left a scar. The same thing is happening in your liver when you leave that inflammation unchecked.
Correct.
And then if you're replacing all of those wonderful hepatocytes, those liver cells, with scar tissue, the scar tissue doesn't do the cleaning and all the wonderful things that our liver does for our body. So you're left with fewer and fewer cells to actually do the job of the liver if you get to the point where you're actually getting scarring, which is basically cirrhosis at that point.
Correct. That's a great analogy and very accurate to the process that's happening within that liver.
So we talked about how common this condition is, but we also know that it's linked to many of these other conditions that are on the rise as well. What are some of those other chronic conditions that tend to go hand in hand with fatty liver disease?
Yeah, so the patients that we are seeing the most fatty liver disease in, that includes your patients with diabetes and prediabetes, so the entire spectrum of what we would call insulin resistance on that end of the spectrum. But then you also have those with other metabolic syndromes. And within that umbrella, you have obesity, which is also on the rise. You have hypertension. The other two biggies to know about would be even the patients with hypercholesterolemia and hypertriglycerides. They are also within that metabolic syndrome pathway, and that also increases their risk of fatty liver disease.
And how do all of these cause fat to build up in the liver?
The big takeaway for this is the insulin resistance. That is really the pathway within your body that's gone haywire on you in this metabolic syndrome, which is all those conditions we just mentioned, that your body cannot handle the sugars, the foods, the things you're taking in and getting rid of it in an effective manner. So the end of that is your body doesn't know where to put it, so it likes to store it in places, and the liver is just very prone to that process.
So if you are someone that might meet the definition of metabolic syndrome, that would be having a larger waist circumference and having elevated blood pressure, elevated glucose, high triglycerides, or low HDL. So if you have any three of those, then you would meet that, and that puts you at really high risk of diabetes, stroke, coronary artery disease, and fatty liver. So something to be aware of. I think a lot of people meet that diagnosis, and we don't ever really tell them that.
And we spend so much time when we're talking about those other conditions and talking about heart attacks and strokes, and the liver isn't always brought up, that it's also impacting that organ as well.
Yeah, and the other thing, too, is when we're talking about diagnosing somebody with MASLD, it only takes an imaging finding of steatosis in your liver, plus only one of those criteria for metabolic syndrome to have your diagnosis of fatty liver disease. So it doesn't take much to truly get that diagnosis.
On that, I know that something that also can be confusing for people is you can have this show up on imaging, but then you get your labs and they're still in the normal range. Should you even be concerned?
Yeah, and that's something I see almost daily in our practice is I will see patients who they might be seeing me for pancreatitis or an ulcer, and I look back through their chart and I'll see, ultrasound in 2020 was steatosis, but no one brought it up. Like we were talking earlier, it's something that we have all just gotten so used to that we're not addressing. So what I would say to the patient that, hey, you have steatosis on imaging, but your liver enzymes are fine, that means you fall into that non-inflamed part or the MASLD or NAFLD part of the spectrum, the true fatty liver. If we don't do anything about that, we can progress over to NASH or MASH, and that's when those cells are getting inflamed from the process, and that's when you start having the issues with the inflammatory pathway, the fibrosis, and the cirrhosis over time. Just because it's not inflamed now doesn't mean it won't necessarily get inflamed later on. So I call that the early stages of the disease process.
And do we know why some people progress on to the inflamed part and some people do not?
We do not have a good understanding of that at present. A lot of it we think is going back to genetics because we are finding more genes and things that are coding and sequencing for fatty storage. It's just like why some people are not necessarily overweight or have that metabolic syndrome pattern, but they have fatty liver. We don't have a full understanding of that as of present.
And when we talk about labs that help us know maybe if there's more inflammation or not, what are some of these labs that patients should pay attention to, or maybe they've been told have been abnormal in the past, but not actually been made aware why?
Yeah, so when we're looking at someone's liver function, there's 4 key tests we look at. We look at their total bilirubin. We're looking at their transaminases, which is ALT and AST. Then we look at their alkaline phosphate level. If those transaminases or the AST and the ALT on your lab value are ever elevated, a little bit above normal, and it's never going to be in the hundreds of fatty liver. It's usually 60, 70, these little smoldering numbers. That's when we should be concerned in having the conversation about, hey, I might have MASH, or hey, you might have NASH, MASH, however you want to call it. And that's the things to look at. And that's the cheapest test that will give you the most information about your liver in a pinch, is getting that complete metabolic panel. And the other things I always tell people look at is, hey, just look at your CBC, see what your platelets are. As long as those are up, let's just do some more work in the background setting.
Yeah, that's one good thing is we do have labs that are able to give us an idea of how our liver is doing, which is an easy test and a cheap test to figure that out. If we do have concerns, my liver's enzymes are climbing, but how is my overall liver function doing? We have other tests that are just simple lab work.
Correct.
And a lot of these are probably things you've had done with your physical exam. So we're talking about the AST and ALT, which would be on your CMP or comprehensive metabolic panel that your doctor probably got. And that platelet count would be on a CBC, or a complete blood count would be what that's called. So you might have access just to look at those. And there's some calculators online that you can calculate this FIB4 number. Is that something that you use when you're assessing? Is it something we should worry about?
Yeah, it's a quick, easy test just to give you an idea of if there is more on the line of fibrosis in the liver, and all you really need is your metabolic panel to get that answer. So if you're someone who's getting your FIB4 and it's a little bit elevated, that would be an indicator for the PCP to go ahead and make the referral out to GI for further evaluation.
And when we talk about further evaluation, we're usually talking about additional imaging. What are some of those tests that someone might recommend if we need to evaluate more about that fibrosis that we were talking about?
Yeah, so in my personal practice and per guidelines, upper quadrant ultrasound or liver ultrasound is the cheapest and most economic test, and most patients have quick access, and I personally like it because there's no radiation involved. Now, if I get an abnormal finding on an ultrasound, maybe there's a little cystic-looking structure or something abnormal, then we make the decision between the other imaging modalities, including things like CT imaging versus MRI imaging. And when we're looking at the liver for that, we would always use contrast as well. So I try to do the least that's effective, which would be the ultrasound. Then if I need to pull the trigger and go beyond that, we can. But really, ultrasound would be the gold standard to get a good look at the liver and really see if there's any fatty deposition within that liver.
And then if you did see some fatty deposition, and let's say their numbers are either normal or just mildly above normal, do you have to go on and do further testing at that point?
No, for the diagnosis of MASLD, the only thing you would need to make the diagnosis would be that imaging finding with steatosis plus one of the metabolic syndrome criterion. Now, there is a pathway you can follow. Is this or is it not this? And then you're either going to end up with MASLD or needing to expand to look for other cryptogenic causes of liver disease. But in my clinical practice, if I see somebody who has steatosis and they have that criteria, me personally, I will also check what's called a fibrosure, which I tell patients, hey, this is like a chemical biopsy. It's a pretty good accuracy, and it'll give me a steatosis score, a stiffness score. They'll give me a NASH score. And if we are below in that fibrosis, that tells me we can still work on this quite a bit.
And that's always helpful to know early on, hey, I have plenty of time to try to improve this before I have too much fibrosis and are headed to cirrhosis. So I think those advancements and being able to have that knowledge for patients is just huge today.
Yeah. And one thing I want to bring up too, you notice we skipped straight to labs and imaging instead of patient symptoms from this disease. And I think that's because most of the time patients don't have symptoms. Is that right?
That is 1,000% correct. It is very much an asymptomatic disease process. Once in a blue moon, I'll have somebody who had just really rapid fatty deposition within the liver, and they'll have some like capsular kind of pain or upper quadrant pains. And then I'll see somebody who's complaining of fatigue, some generalized malaise-like symptoms. But liver disease isn't something that's going to give you nausea, vomiting, diarrhea, shortness of breath, chest pain. It's very much a silent process. So most of the time when I'm meeting patients with this, it's because somebody ordered a scan, it showed something, and they wanted something else done about it.
That can be confusing because some people associate liver disease with just cirrhosis. And
Correct.
So if you've ever known someone who's had cirrhosis, they have lots of symptoms. And so that's how this condition is just very sneaky, because very early on, unless you're having labs or imaging, you're unsure if you even have this diagnosis, and you don't want to find out when it's too late.
Yeah, and the other thing on that same topic, there's so many patients with fatty liver, and there's this stigma around liver disease. So I see all these sweet little meemaws and peepaws, and we're saying, hey, you've got cirrhosis of the liver. And they're like, no, I don't drink alcohol. I don't do this. So we have this negative connotation with liver care, cirrhosis of the liver, and this old mindset that, hey, you have to drink alcohol to end up in this situation. But that is one of my pet peeves and something I'm very passionate about, making sure people know, hey, this is diet-driven, this is fatty liver-driven. There's nothing necessarily that you did to get here.
So let's talk about how we get there. What are we doing that's making this happen more and more often?
So when you look at the data, what you will see is over the last 30 years, there has been this massive explosion of not just fatty liver, but all of the domain of metabolic disease processes. And then I have to take just a retrospective look and say, what changed 30 plus years ago? So I'm a 1993 model. That'd be right around the time I come into this world. We had a lot of fast food. We had a lot of processed foods, but it didn't start with my generation. If you extrapolate and go back 30 more years, you're at that turn of the war time frame. And at that point in time, we went from being, I always equate things back to the sociological principles, we went from more of a hunter-gatherer, we went from growing up on farms, having access to really clean whole foods, real clean ingredient foods, to relying on the boxed, processed, getting bombarded with things that are not good for ourselves. So it has to do with multi-generational food changes and how it progresses to where we are now. It's not something that just happened 30 years ago, but what we're seeing is the people 30 years beyond that are now presenting with fatty liver. So it's something that is interesting to watch and interesting to follow. But the unfortunate news in that frame of thought is if you look at the GI statistics, the patients with liver disease is going to double by the end of the decade. And that's just any form of cirrhosis in and of itself doubled by the end.
Cirrhosis is a disease state that requires a lot of care and frequent treatments and is very costly as well. So that is not exciting to hear that those rates are going to be that high that quick.
Yeah, and as you already mentioned, patients with cirrhosis have a lot of symptoms. It's a particularly uncomfortable disease to have because it does cause so many issues. And fatty liver disease is the most common reason someone even gets a liver transplant now. We really need to be trying to intervene so people don't get to that point. But it seems to me, this is my personal kiddie views, it's like the emergence of high fructose corn syrup and the sudden ability to make these quick, easy access ultra-processed foods that seem to correlate with this rise in metabolic disease and subsequent rise in fatty liver disease. So I feel like that's got to be a main driver of this.
Yeah, the corn syrup and all the preservatives, all those dietary changes that we all just inadvertently went through without thinking about it is certainly leading to this increased rates of metabolic syndrome and fatty liver in particular. And on just other GI note, the corn syrup thing, and you look at the data on colon cancer, that is being driven too by the corn syrup and the increased sugars and fructoses. And it's quite the conundrum we're finding ourselves in today.
And I know one of our very early shows that we did on this podcast, we talked about just the rapid increase in those added sugars that have been placed in our diet over this period of time. Because just as we had mentioned, this isn't just with fatty liver disease. This is also why prediabetes and diabetes are just skyrocketing because, again, they're all linked to insulin resistance in our population.
While we're on the topic of diet, can you talk to us about what someone should do if they are wanting to improve their diet to help their liver?
Yeah, so when it comes to diet modifications for fatty liver disease, I try to keep it as simple as humanly possible. So the biggest change I tell patients is let's cut out any refined sugars. Let's work on eating whole food nutrition, make sure that you can recognize the ingredients of the foods you're putting into your body, and let's increase that protein intake because protein is paramount to function within your liver. And beyond that, the only major recommendation, there's two that I make in addition to weight loss, is put all that together. Things like the Mediterranean diet is very helpful for liver disease. And then black coffee is very helpful for liver disease. So when you're looking at diet, I try to say, okay, eat a Mediterranean diet, increase that protein intake, and drink that coffee.
And that Mediterranean diet is one that's very high in fruits and vegetables and whole grains. It's all these things we talk about on our show.
Yeah. And so more of those monounsaturated fats, less of the saturated fat, and then really getting rid of the added sugars.
It's the one diet I tell patients, it helps address all domains of your metabolic syndrome. So if you have hypertension, there's not a lot of sodium. If you're someone with diabetes, it's pretty low in sugar, pretty low in carbs, it can be a good option for you. So when we're trying to tie this up, I like putting things in nice, neat bows. It would be the single easiest option for most patients. And then on the diet topic, with my research and looking at fatty liver, even before I started looking into this at the graduate student level, I realized very early on that we have a health literacy problem in our population that we're taking care of. So I'd be telling patients, hey, eat more protein. And then I would ask them, what is a protein? And most patients couldn't answer that question. I think, too, when we're having these conversations, really giving clean-cut examples of what a protein is, what, to eat or not eat is very important going forward because most patients can't read a food label.
And yes, I really do think that sometimes as healthcare professionals, we give too broad of recommendations and then leave our patients trying to search for the answers on their own. And that's what gets them stuck with the wrong advice many times because you can search and find whatever answer on the internet today, whether or not it's the right one or the wrong one. And so trying to give that more targeted information. And the great thing is, for instance, the Mediterranean diet, advising that there's lots of information about the Mediterranean diet and can steer someone in the right direction when providing that.
Yeah, and most patients are very successful with that because it's not a super restrictive diet. You still have access to really clean protein sources, nice whole grains, good healthy fats. So it's something that you can make that dietary and lifestyle change to and not feel like you're starving yourself.
And if you are someone that is struggling with fatty liver disease, I would say if you are drinking sodas or some type of sugary drink or juice, sodas on a regular basis, that's probably the best place for you to start.
Alcohol and liquids across the board is the easiest adjustment for patients to make to really clean up their diet and get rid of a lot of these excess sugar. So I had one patient in the hospital diagnosed with NASH, back in the day, now MASH, and they were like, I don't know how I got fatty liver. We were just going back and forth, and then I saw the family bring in 2 of those big gallon jugs of Milo sweet tea. And I'm like, how much of that do you drink a day? And they're like, I drink about 1 of those a day. I'm like, okay, that's your problem. Let's get rid of that. Let's try to drink more water, unsweetened beverages, and then that's a great starting point for all patients.
Yeah, we like simple.
Yeah, same.
That makes it very simple. I do want to backtrack. Before we go down the alcohol realm, you mentioned coffee, and I really want to put this information out here because our coffee drinkers out there may be really excited to hear what coffee can do for their liver. So can you please explain how coffee can be a positive for these patients?
Coffee is, if you ever have the privilege of or disprivilege of reading one of my notes at work, when we're talking about fatty liver, coffee is second thing that's bulleted behind 10% body mass reduction. So for many decades now, we have known that coffee has a great effect on the liver. In particular, it helps reduce fibrosis, helps with the fatty liver deposits within the liver as well. But when you look at it in broader terms, depending on the site you're looking at, it can reduce your incidence and progression into cirrhosis by up to 60%. It can reduce your cancer progression by about 47%, depending on what site you're looking at. There was a really fun statistic a few years ago that said if you drink 2 cups of coffee a day, it reduces your risk of all-cause mortality by 25%. But the big thing is knowing that you can reduce your mortality, you can reduce your progression to cirrhosis, you can reduce your risk of getting liver cancer from fatty liver disease, which would be the hepatocellular carcinoma branch of cancer of the liver, by a significant amount. So the recommendation is 3 to 5 cups a day, but if you're someone who's already a coffee drinker, try to shoot for at least 2 cups beyond that, which is proven to be most beneficial to you. The other question I get is, does caffeine play a role in this? And the short answer is yes and no, so not a great answer. But I would tell patients try to get as much of the caffeinated version as you can, but getting the coffee in any variety is better than no coffee at all. The other question I often get is, does it have to be black coffee? And unfortunately, you would think in the 40 years of data, we would be looking at black coffee, decaf versus full calf versus caramel macchiato for Starbucks. But no one has really looked at that. And the big reason why is you have someone with fatty liver disease, and that was just too much excess sugar. So to get the peak benefit, no cream, no sugar, nothing that's being as an additive to that product.
And when we talk about a cup of coffee, we're just talking about 8 ounces of coffee, right? Because
Correct.
I know sometimes we're like, oh, my coffee, but my morning coffee is probably more 2 cups actually that I'm having first thing in the morning. Keep that in mind. The actual ounces, a cup is 8 ounces.
Yeah, measure it out. And then the other concern patients have is like, hey, I have issues with AFib. I have other issues. I might have too much urination or whatnot from the caffeine. So I always say try to get as much as you can. And if you're having issues with the caffeine, cut it to the decaf or no calf, and then cut it off at noon. Get whatever you can in by noon. That way you're not affecting your sleep cycle, not having any of these other unwanted side effects of the coffee.
Yes, we talked about that in our sleep series.
Yes.
We want that caffeine before noon so we also don't mess up our sleep.
Oh, yeah. I'm now to the point in life that if I have a Diet Coke or any type of caffeinated beverage after 3 o'clock, it has definitely had a negative effect on my sleep. I just sit there like, staring at the ceiling.
I'm the same way.
Yes.
So that is a win for the coffee drinkers of the world.
Hooray!
But now let's flip back to the other beverage you mentioned. So we talked about how alcohol, most people know alcohol is not good for their liver. But what about this moderate use of alcohol? How can that impact our liver? And if someone does have fatty changes, what should they be doing with their alcohol consumption as well if they're trying to decrease that risk of progression?
Yeah, so my recommendation across the board for even mild to moderate alcohol use in setting of fatty liver is to just take it off the table. Remove that variable from the equation and let your liver defatitize. That's not a real word, but it makes sense for what I'm saying. Just to take that off the table, give it a chance to heal itself up. I always have the conversation with patients and I say, hey, what is an alcohol at its base? Let's go back to chemistry class. An alcohol is nothing more than a fermented sugar. And when your liver is breaking that up, it's going to have part of it stored as fat. The other part is going to be this really toxic inflammatory compound that leads to that inflammation and things that we see with like alcohol hepatitis. I'm like, take it out of the equation, remove that variable, and give your liver the chance to do the things it's supposed to do. Now, that's why we also have MET ALD, so that way we can further quantify. But if you're on that other end of the spectrum, I say no alcohol is best.
And so let's say somebody has had some mildly elevated liver enzymes and they were found to have some fatty liver disease. They saw you, they had been drinking, let's say 5 to 10 drinks a week. You told them no alcohol is best, and they said, okay, I'm going to go no alcohol. How long would you expect it to take before you saw those liver numbers come back down to normal?
With all things in alcohol, tell patients give it 90 days, so about 3 months. If you come in with alcohol hepatitis, the well-known pathway that we all know is the remodeling, the stability of the liver happens in about a 3-month process. So I say, hey, take it off the table, come back, let's get repeat labs in 90 days, see where we're at. Usually as long as the alcohol has been removed and there's no underlying liver disease at play, it is better, typically in the 90-day window.
I think that's really important to say to someone. We always talk about how important expectations are, because a lot of people will think, okay, well, I'll quit drinking for 2 weeks. And then they come back and don't see that it's made a difference, and then probably feel like that doesn't make a difference for me. So I'll just go back to...
Yeah, you can get patients who might have had just a weekend bender or whatnot. Their enzymes might be just acutely elevated in that window, and it could look better in 2 weeks. But I always set the realistic expectation, hey, give it 3 months. Let's hone in on your nutrition, really do the right things here for the next 90 days, and then get repeat labs.
Now, for someone who on imaging, maybe their labs were normal, but they were found to have some of these changes on their liver of the fat deposition, how long does it take to see that go away on imaging?
So that is a bit of a conundrum in and of itself. So the process, if we do all the right things, we're doing the 10% body weight, we're doing some of these medicines to help, all the studies look at about a year. So 52 weeks from onset of us doing something to seeing good resolution both in labs and imaging. So it's not a quick fix by no means. So it's something to be slow and steady wins this race. It's a marathon, not a sprint.
And is that the same amount of time needed to see changes with fibrosis as well?
Yes.
Okay.
You have brought up a couple of times now losing 10% of your body weight. Can you tell us a little bit more about that number and what the importance of that is?
Yeah, so when you look at some of the older hepatology studies, this is something that we have been recommending for decades at this point. So what they found is if someone loses 3% of their body weight, it slows that storage process of fat in the liver. If they lose 5%, it pauses it temporarily. And when you cross between that 7 and 10% mark, you actually start reversing that fatty liver. So the very first recommendation, besides getting rid of the sodies and getting rid of your liquor, is to lose that 10% of your body weight, because that's the single most impactful thing you can do to help reverse this process. There's a great study that came out. I just found it in an article probably within the last couple of weeks, and they looked at the use of semaglutide. And everybody who's listening is probably familiar with the weight loss shots, as we're all calling them. And they looked at patients with diabetes and fatty liver who is using this medicine versus a controlled group who did not have exposure to this medicine. And what they found over 52 weeks is the patients on the GLP-1 medicine lost 10.5% of their body mass, and their steatosis scores were completely reversed. Whereas you have this second control group, and they only lost about 3% of their body fat percentage or 3% of their body weight, and then less than a third of them had made any meaningful impact in their fatty liver.
Yeah, because 10% of your body weight can be difficult to do. I think that's one other really great benefit from this class of medicines that has come out to really help people that are struggling with fatty liver disease to get it to really start turning around.
Absolutely.
And I know we want to talk some about the medicines that can help in addition to that. But before, I want to go back to a little bit of the lifestyle aspect. What about exercise? Does exercise make an impact on this condition?
Like all metabolic syndromes, yes, 1,000%. And when you go look at AASLD guidelines, there's no tried and true guideline for exercise recommendations. But in my personal clinical practice, I do the American Heart Association 150 minutes of light aerobic exercise weekly. For most patients, that's an easy starting point because it's just walking your dog around the block a few extra times a week. And then from there, once we see them in clinic and follow up, I'll say, hey, have you thought about just like TheraBands, just something lightweight, low resistance, just to help build some muscle? Because that's something that most patients with liver disease, especially as it's progressing, will start to lose muscle over time.
Yeah, and that's a symptom that sometimes people might be one of their first symptoms that they realize they have liver disease is that muscle loss. It comes out of nowhere. They're like, what happened?
Correct. And patients look at me like I got three heads when I'm talking to them because none of my questions in my first time meeting you for liver disease is going to be, does your belly hurt? Are you having nausea? Do you have diarrhea? No, it's how is your sleep? How is your appetite? And when did you start losing muscle mass? Because those three indicators are telling me that, okay, we're having some issues with circadian rhythm. We're having issues with just how your liver's metabolizing and albumin and all these other things. I'm like, okay, that's something we need to get some more imaging and look at this a little bit more closer.
Can you elaborate a little bit more on the connection with sleep?
Liver disease has been well documented to have a negative effect on your circadian rhythm. And actually, I talked to a colleague about this within the last couple of months, and the theory is most patients with cirrhosis is zinc deficient at baseline. And zinc is a vital component of that metabolism because we all know tryptophan to serotonin, serotonin melt, that whole pathway. Zinc is utilized to convert that serotonin over to melatonin to help with your sleep. So what you end up with patients with liver disease is they'll fall asleep, but they wake up all night long, and then they catnap during the day as a result. So that's usually a very good indicator that someone's having issues early on.
And I know it was talked about a lot with my patients with cirrhosis, how awful their sleep was. Like it is. And it's frustrating because it's really hard to help them with that as well.
Correct, because the sleep medicines, the Ambiens, the Seroquels, and all these other medicines within that class, they're not a great option for liver disease patients. They're not the easiest to metabolize. Most of them are metabolized in the liver, and then they'll take it at 9 o'clock at night. But then I'll see them in the hospital the next morning. They're groggy and sleepy, and they just don't look well because of it. There's not good options in that besides your usual zinc replacement, and then also like melatonin for that. Pretty benign things for them.
So all these pillars of lifestyle medicine. So we've got diet, exercise, getting good sleep.
Absolutely.
Would be helpful. And probably just stress reduction in general, and having a lower cortisol, lower inflammatory state would be helpful as well.
Absolutely.
And alcohol. We have covered
Look at that.
all of our pillars of lifestyle medicine.
Well, that's what I was thinking when I was coming on. I was like, wow, liver disease is like the best diet and lifestyle podcast topic that you could possibly have, because everything I tell patients, I jokingly say, hey, 90% of this is you in your kitchen. Only 10% of it is you seeing me in clinic getting an ultrasound and a blood test every 6 months. This is all on you, and that's why I do what I do. Just the ability to teach and educate and empower patients to really take control of their health, to make these changes to prevent these really horrid complications down the road.
And that's the exciting thing. There are so many conditions that people may encounter that they have no control. Right? Like they get a diagnosis, there's nothing that they personally can do to reverse it. But this is one that you can feel power back and know that if I make changes, I can reverse this. And that's exciting, because if you have experienced a condition that you can't have any control over, you wish that you could just change your diet in order to feel better.
Yeah.
And I would say, I doubt you have to be perfect. When we're talking about doing all these things right, that can also feel overwhelming. If your lifestyle right now is not great, you don't have to be perfect with all of these things. Just remember, making a little change, just starting somewhere, you will see progress and improvement in this.
Yeah, absolutely. I worked as a client with Beth Cronenberg here in town, and she has this great saying about, okay, you're planning your meals for the week. You're going to have 21 real meals and some snacks during the week. Shoot for that 80% mark. Really try to hone in and get as close to perfect as you can, with the expectation that we're all busy. We all have life. Try to get as good as you can, knowing that's the best you can do.
And you can go back and listen to our episode with Beth Cronenberg for more thoughts from her.
Yeah, we did that one back in January. It was excellent. So another question is, there's lots of supplements out there that are promoted as helping with liver health.
Liver cleanse. And I feel like I see a million things.
There are just lots
Clean
of
your
things
liver.
talking about the liver. Is there anything out there that patients should be very cautious on? And then the reverse, is there something that could actually show some benefit? We don't have to talk about all of them, because literally there is a bazillion marketed.
Correct. So the first thing I always tell patients is no to anything that's labeled as a liver cleanse. I have had more than one patient in the hospital, because remember, I'm not a community gastro provider. I'm not in the clinic. I'm a hospitalist-based provider. I've had more than one patient come in with an acute liver injury or drug-induced liver injury from these unregulated, really toxic, highly potent detox cleanse products. So across the board, I say stay away from those. Don't order it from the Amazon. Talk to me before you're going to take any supplement of that variety. When it comes to these supplements, I try not to overcomplicate it. The biggest one that I give everybody is, okay, you're going to take a multivitamin with minerals, because you're going to be depleted on everything just at baseline. From there, the biggest things I also add is a fiber supplement, because you all have covered fiber on the podcast. The U.S. diet is terrible at getting enough fiber. And so I say, okay, if you're somebody that doesn't have bloating, you're going to take some Metamucil. If you're someone who has bloating, you're going to take some FiberCon, and we'll work our way from there. When you look at the other data on the common things, if you Google it, the first thing that will pop up will be vitamin E, for example. In the right patient, that's an okay thing, but when you start digging into the data, it's 50 one way, or as my partner says, 6 one way, half dozen the other. You can get studies that show good benefits, some that don't. In the right person, in the right population, it's a pretty benign supplement to take. So anywhere from 60 to 800 units is fine, unless you're someone with biopsy-proven cirrhosis, someone with prostate cancer history, either personal or within your family, or someone with heart disease. So I wouldn't be using that in that particular patient population. Other than that, I try to keep it as clean and simple as possible, because I'm already inundating these patients with so much information, and the compliance with taking supplements is not the best.
Another one I just wanted to bring up is, what about thoughts on the omega-3s? Since we do know that omega-3s are anti-inflammatory, can help with triglycerides, is that one that You ever see any benefit for the liver?
That is something I actually use in my patients with known hypertriglycerides. I go ahead and just start it because of the benefit and the fact that our diet is so poor in our country. I don't know if there's any good studies that show its benefit in fatty liver disease, but if you have those triglycerides that are elevated, it is a pretty benign thing to try.
And the other thing you can do is increase it in your diet. Kitty, remind everyone where those omega-3s.
Because I'm already like, yes, I have an in to say you could sprinkle your hemp seeds on there, and that would be a great source of omega-3, or your chia seeds.
Seeds and nuts,
walnuts. Yeah.
And those fatty fish. That's another way to get the omega-3s in our diet. And the Mediterranean diet is high in omega-3s in general. So another connection there when we talked about that.
You know what I've started telling patients, because the big thing, like I said, health literacy is bad and they don't know what a protein is. So I'm like, animal meats. And like, which one should I be eating? I'm like, okay, how do I explain this? So my father-in-law actually had a diabetes educator. I was like, eat the animal with the fewest number of legs. And that was mind-blowing for my patients. So like your fish is the healthiest, and you get your fish, shrimp and whatnot, and then from there you can get your chicken and your turkey, pretty lean cuts of meat, and then you can get your four-legged critters, and then it's just what have you. But that has been so helpful in explaining the right proteins for patients being. So try to eat more things with fewer legs, and that's a little bit better for you. But
I have not heard that.
I haven't either.
But it helps so much.
You mentioned already the GLP-1s, the Ozempic and Mounjaro and all of those that have come out. Is it indicated to actually use those for fatty liver? Like, I know a lot of people struggle with getting insurance to cover it when they're wanting to take it just for obesity. If it's someone that has obesity and fatty liver disease, are they covering using that now? So
the ones for obesity, yes. So what is it, Zepbound or Mounjaro, one of the two that has a true obesity indication. If they are obese, we can send them to, I use the medically managed weight loss clinics for that. But there is no clear indication for its use just for fatty liver as of yet. But we have had 3 really good studies looking at its use that shows its benefit. In my personal practice, I've had more than one patient say, hey, I can't lose this weight. Across the board, I say, okay, 6 months from now, come back. We're going to weigh you. We're going to look at how well your labs are looking, and we make that decision. And if they're still struggling, I say, okay, there's 2 options here. We can either go down the medically managed weight loss route, or we could try this new class of medicine designed specifically for fatty liver. And I won't exhaust both of them at the same time out of the gate. And I say, we can try to navigate this whichever way you want. And then we risk stratification, just talk about the 2 different options there.
So what is this new drug?
So it's a new medicine. It's been out for, I would say, a little bit over a year, and it's called Resdifra. I won't even try to say the chemical name of it because I would butcher that. But it's within this class of thyroid hormone receptor beta agonist, and it helps block that fatty infiltration, that lipid pathway within the liver. So if patients have fatty liver up to F2/F3 fibrosis, we can start this medicine, keep an eye on this fibrosure, the chemical biopsy as I call it, and it's proven to help reverse fatty liver in most patients.
That's amazing.
It is. Is it pretty well tolerated?
Yeah, the biggest side effects, like any GI medicine, nausea, vomiting, and GI upset. Beyond that, there is some weird risk for gallstone formation in certain patients, but it is pretty well tolerated by most patients.
And is that something that a patient would have to be on lifelong, or is it something that you take until you see the reversal and then you're able to stop it?
We usually stop it, and we have that conversation at the 1-year mark.
That's great. We love when you don't have to stay on something forever.
So even if they haven't changed their diet much, it seems to have some lasting benefit.
It has a good effect, yes.
Oh, that's great.
But most of my patients, when I start them on it, it's not like those controlled substance contracts, but I sit down, we have a very good heart-to-heart, and we're talking about the fatty liver and why I'm so passionate about keeping them from this progression. And by the time they see that I care, they care, we care, they're really invested in these changes.
Another one I wanted to bring up, because I think it gets confused a lot, is statins. So our cholesterol medication. We know elevated liver enzymes can be a side effect of statins. And so I feel like I see a lot of times people have elevated liver enzymes more from their fatty liver disease, and then they get their statins stopped because it's worried that that's causing it. What's your thought on that?
So at our practice facility, we don't regulate that anymore. If you are on a statin for your cholesterol, we allow you to continue that unless we have concerns for drug-induced liver injury, which we all know you're not going to present with that same kind of LFT pattern with that. But the older literature said, hey, stop statins, can be harmful on the liver. But unless you're someone in that immunoallergic pathway with that drug-induced injury, it is perfectly safe to continue taking your statin to address this other part of your metabolic syndrome pathway.
Yeah, probably because they have an anti-inflammatory effect as well, which I would think would be possibly protective.
Yeah.
So we have talked about a lot about wanting to be aggressive, get this diagnosis, do these things to reverse it because we want to prevent cirrhosis. How long does it take for cirrhosis to actually develop from someone who has fatty liver that then goes to fibrosis and then to cirrhosis? Is this something that happens within a couple years? Does this take a decade? What is that normal timeline?
So that varies based upon the citation you're looking at. But what I can tell you from clinical experience is typically from your diagnosis of fatty liver, because we're not diagnosing it right as it's happening. We're seeing it 10 years after you gain 50 pounds or whatnot. The progression to go from fatty liver to cirrhosis of the liver is typically a decades-long process. Much like our diet changes that led to the fatty liver, it also takes a while to progress to that point. As the GI provider, it's so frustrating when I see people coming in with fatty liver cirrhosis, because had we had this conversation 10, 15 years ago, we could have reversed this outcome for you.
Yeah, so I think that's great to know because, again, it's hard to totally change your lifestyle. If you are someone that has fatty liver disease and you need to be making a lot of changes, you don't have to do them all in a 3-month period of time. You have time to just start doing things one at a time and get to where your liver can heal itself from this inflammation.
Yeah, and I encourage patients, set tiny goals of what I'm telling you. I don't expect you to go from a no coffee drinker a day to drinking 3 to 5 cups of black coffee a day. So I say, set your goal. Say, okay, today we're going to do a cup, but we're not going to do the whole cup of coffee. We're going to do, the trick to get them to drink it would be do half a cup and then put some hot water, make an Americano with it. That takes the bitterness out. That lets them be more tolerated. It's a little easier on their stomach. So try it that way and then say, okay, this week, 1 cup of half. The next week, we're going to go to 2 of these. And then next week, maybe 3 of these. And then over time, we remove some of that water from it just to empower them to, hey, I can do this. Small and tiny changes will make a big improvement over time.
I love coffee so much that it's like I'm hearing, wait, someone doesn't want to drink coffee? This person exists?
Oh, that is the hardest. Trust me, I can get someone to quit drinking alcohol or quit doing things like meth quicker than I can a lot of people to actually drink coffee. So I'm like, really? I love this. I just had the pot, just go around the hospital. I'm having a good old time. But yeah.
So I do think something else that we want you to think about if you're listening to this is if you are unsure about your liver and no one's ever mentioned, hey, we're concerned that you may have fatty liver, but you have these other diagnoses of obesity, diabetes, metabolic syndrome, high triglycerides. This is something that maybe having that discussion with your primary care. Do you have any concerns that I may be developing fatty liver, or can we look into that just because of that strong correlation with those other conditions so you can know where you stand and are not someone that goes many years without knowing that it's occurring?
Do you recommend anyone that, let's say, has had an ultrasound or a CT scan of their abdomen for other reasons and has been found to have some fatty liver disease, do they all need to come see you, or is this something that they can just start working on their own and with their primary care doctor?
Yeah, so unless there's inflammation, we're seeing that NASH/MASH, it is okay just to work on it on your own and then go see your PCP to talk it through. Once you start having that inflammation, though, it's a good idea to come see us just so that way we can be addressing any other modifiable risk factors and addressing that inflammatory pathway, maybe considering some of this medication assistance that we have at our disposal. The only other thing I would say is if you're someone with diabetes in particular, the latest statistics for patients with diabetes is greater than half of them have fatty liver. So that is a very high-risk population, and that's the ones that we're seeing this kind of emerge and a little bit quicker progression to cirrhosis than those around them, probably because of the insulin pathway. So I say if you're a diabetic, talk to your family doctor about getting a screening or getting an ultrasound, just looking at that for you. And if you're someone who is in that high-risk category, just go ahead and come see us, because the sooner we know about it, the sooner we can do something about it, especially if you're in that diabetic, pre-diabetic, really high-risk group.
Well, you've given us so much great information today, and I feel like this has been just a course in lifestyle medicine as related to the liver. So that's wonderful. So what we want to leave you with today is, remember, there's a lot of names for fatty liver disease. So you might see fatty liver, you might see something called NAFLD or non-alcoholic fatty liver, MASLD, metabolic dysfunction associated steatotic liver disease. You may see mention of hepatic steatosis on an ultrasound. All of that stuff means there is some fat in your liver, and you need to pay attention to that. We get more worried when that fat starts having inflammation, and then you're at risk of scarring and cirrhosis. So we want to act before you get to that point, and we want to do that mostly with lifestyle change. So remember to really look at the ultra-processed foods. You want to reduce the drinks that you have that have added sugar. You want to reduce your saturated fat.
anything that's packaged and easy is probably something that's not great for your liver, and you want to increase those whole foods, fruits and vegetables. We want to exercise because we know that helps on multiple different realms with the liver. Basically, what you told us today, Kyle, is no alcohol is the best amount of alcohol if you're dealing with this. And so really try to minimize that the best you can. If you can make some significant changes, you're probably going to see your lab start improving within that first 90 days and about a year to see improvement in your imaging. So losing 10% of your body weight would be our goal, but you're even going to see benefits at that 5% of halting that fat accumulation. Even little bits are going to help. He wants to make sure that you are avoiding anything that says liver cleanse and instead really focus on your nutrition as the main avenue of fueling your liver. Luckily, we know that there are some medicines out there now that have promise both in the obesity realm and the GLP realm, as well as this newer medicine that specifically targets fatty liver disease. So that's great to think that we have more options for patients as well. And hopefully we can decrease the rates that we're seeing this in our community.
And we can't forget that coffee is actually medicine here.
Absolutely.
So hopefully you all have enjoyed this show, and please don't forget to share this show with others. Leave us a review. Be sure to like our show. We love to hear from you. If there's other episodes that you want us to do, you can always send us a text or send us an email at contact@thestartinggatepodcast.com, because we love to hear what you want to hear from us.
We're looking forward to talking next week with Dr. Sunana Sohi, a gastroenterologist. A little bit more about the gut microbiome, some common GI complaints, irritable bowel syndrome, and every other question we can think to ask her while we've got her.
We'll look forward to talking to you all next week.